Lastly, we move on to the cervical flexion-rotation syndrome. Now, what we see with these patients is painful and or limited cervical flexion and rotation of the cervical spine. It's not only what we saw with cervical flexion syndrome, but we're also going to see probably more unilateral or asymmetrical presentation of the pain in the posterior aspect of the cervical spine. And then you'll have that painful aspect of rotation as well. These patients will likely complain of pain with checking blind spots, although that can be seen with patients that have extension rotation syndrome as well. The blind spot aspect is just showing that there's a rotation component to the movement impairment syndrome. These patients may also regularly perform activities that require repetitive positioning in the neutral posture. So think again about military type posture and people who are always thinking of trying to be sit up straight and sit up tall. Some associated signs we see again are decreased thoracic kyphosis, heavy arms and chest, resistance to passive elevation of the scapula from the increased resistance from the scapular depressors and retractors, straightening of the cervical spine, loss of that lordosis, depression of the shoulders, regularly trying to maintain that neutral posture, possibly with some rotation as well, and it may have some hearing or visual impairments. Their neck may present with like a slight torticollis as well with some side bend rotation, so be aware of that. The tests that we want to do include the tests from the cervical movement, flexion movement impairment syndrome as well. Either in standing or sitting, we can have the patient actively flex, noting greater motion in the lower cervical spine because their upper cervical spine is already flexed. We want to repeat in the slouch posture and see if that reduces their pain, because likely it was painful initially. We'll see some pain with rotation and possibly some compensatory flexion or side bend. Have the patient get in the slouch posture and repeat rotation. Also, you could support the shoulder girdle and repeat. You could give them cues on the proper method of rotating. If any of these reduce the pain, then that helps confirm our flexion rotation syndrome. Overall, what we're trying to do is get rotation for that aspect of the test to occur throughout the cervical spine and not just in the singular aspect. We may note slight rotation of the cervical segment with single arm flexion. So again, that's where we're placing our fingers on the spinous process, having the patient raise their arm, and noting some wiggling under our fingers of the spinous process. You can repeat with a slight cervical extension, so having the patient slouch slightly. You can have them repeat with both arms flexing or with a little scapular assistance. Again, I do not like those tests much at all, just because it is so subjective what you're feeling into there. And then getting the patient into the prone and quadruped position, you can have the patient actively extend their cervical spine. Likely you'll see some pain and possibly a little excessive posterior translation of the lower cervical spine. You want to repeat cueing with a little bit of segmental type motion, initiating the motion superiorly and working their way down. You may see, if you have the patient rotate, the same painful and limited motion if they're in that neutral spine, but if you have them go into a little more lordotic posture, an improvement in what they feel. You do that either in prone or quadruped. Again, the pain and restrictions and habits all tend to be more asymmetrical when it's a rotation type component and maybe unilateral. And that applies to both flexion rotation and extension rotation. Now, in summary, some things you want to be aware of and some general concepts for movement impairment syndrome examination. Start with assessing the range of motion in all cardinal planes and note any pain that's reproduced with each one, their mobility restrictions, and just generally how the patient is moving. Those things alone can often give you an idea which classification to place them in. After you've noted that, you have the patient repeat the range of motion. with corrected movement, either using verbal cues, tactile cues, possibly passive support of their shoulder girdle or rib cage, or possibly with some added stability, whether it be adding a chin tuck for extension bias type patients, or adding a slight lordotic posture for the flexion bias patients. You want to challenge the dysfunctional region in alternate positions. So if we note that the patient is having a difficult time rotating, try it again in supine, try it again in prone or quadruped, and see if those patterns are kind of reinforced with each position change. And then cluster those findings in order to identify which movement impairment syndrome the patient is going to be classified into. Once that direction of susceptible motion is determined, it is essential we find any activities, habits, postures, motions, whatever, that the patient performs each day that contributes to the dysfunction. Because that's going to play a big role in what we do with our treatment plan. We need to find what it is that they're regularly doing that's hurting them so that we can try and educate them or adjust what they're doing to minimize those repetitive motions and prolonged postures that are reinforcing their movement impairment syndrome.